Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today, I want to circle back and talk a little bit more about atherosclerosis, heart disease, and specifically coronary artery calcium scanning. And we're going to talk about a specific patient very close to me and use him as an example of how I approach heart disease, how I approach heart disease prevention specifically. And that person is me. Okay, so just recently I had the second CT coronary artery calcium scan that I've had in my life. So I had one at age 40, and I'm about to turn 50 next month. So I figured, hey, it's been 10 years. Let's see how things look in there. And spoiler alert, not good. So we're going to talk about what I'm going to do about that, and I'm going to share my results with you guys. So before we kind of dive into all of that, let's talk a little bit about atherosclerosis. This is the leading killer worldwide of both men and women. It beats cancer, it beats trauma, it beats everything else. Okay, more people die of heart disease and complications of cardiovascular disease than any other cause. Okay, so this is the progression of atherosclerosis. I really like this little diagram here, and it shows how it progresses from this initial lesion just within the intima of the arterial wall, and then it progresses to this full-blown, like, occluding cholesterol plaque with a fibrous cap that eventually is what ruptures, the fibrous cap, I mean, and then leads to sudden occlusion of blood flow distally to this lesion. Now, when that happens in your heart, that's a heart attack. Usually an ST, what we call a STEMI, an ST elevation myocardial infarction, is kind of the worst version of that. If it happens in a cerebral vessel, it can lead to a stroke. It can happen in your extremities as well. The condition's peripheral vascular disease. I see all three of those frequently on my emergency room shifts. There are 6 basic stages that the American College of Cardiology uses to define these, the progression of these lesions. And it's a bit academic, but and maybe not that important for the average person to be familiar with this. But as we go through them, it'll kind of make sense. And this picture is actually very helpful. So, in stage 1 and 2, you have this initial lesion. You're just starting to get lipid deposition, and by lipid I mean ApoB containing particles, so LDL, VLDL, ILDL, lipoprotein A, which we're going to talk about quite a bit. They penetrate into the endothelial wall. They set up shop there. There's a local inflammatory reaction. There's recruitment of macrophages. Those develop into something called foam cells. And there is recruitment of a whole host of other intermediate immune factors that lead to further progression, as you can see on this chart, where you go to here at stage 3. And then as you go on to stage 4, this is what's called an atheroma. And this is where it starts to really become recognizable as like the classic atherosclerotic plaque that we're all used to seeing. You start getting even more lipid deposition. As you progress, you start to get the development of this fibrous cap. Okay, and this fibrous cap is initially quite thin, and then as time goes on, it becomes thicker, it becomes more calcified. We're going to talk about that in relation to CT calcium scoring. Anyway, you can see that the picture kind of speaks for itself. Things just get worse and worse and worse, and really here at stage 5 and 6. These are the lesions that are more likely to be prone to rupture. And there's a lot that goes into plaque rupture. In fact, it's not always the big occluding lesions that are prone to rupture. If they have a very thick fibrous cap, they're heavily calcified, many times those are less likely to rupture than these more intermediate, like lower grade lesions that are not only are they actively growing and inflamed, but they have a thinner fibrous cap that's a little bit more easy to rupture, and those are the ones that lead to an event. So that's why a 40 or 50% lesion can sometimes be a fatal lesion, because again, it's more likely to rupture than perhaps like a really old, totally calcified 70% lesion that you've had forever. That plaque is in many ways can be more stable, and not as prone to rupture. So anyway, so this is the progression of the disease. Now this slide here, guys, I want to spend a moment on this. When I learned about this, this permanently changed the way that I look at the development of atherosclerosis and heart disease, and the way that I think it should be managed. And a lot of people that are in this field also agree with me. Atherosclerosis starts in childhood, like early childhood. So I've talked about this in other talks, but there are autopsy studies of children at age 5 or 6 that sadly were killed in car accidents or died of other reasons, and on autopsy they have the very first sign of the development of atherosclerotic disease. So we're talking like stage 1, 2, and even 3 lesions. So this chart here shows the prevalence of atherosclerosis across ages. And you wonder, well, how did they find this stuff? Well, they went in they did a cardiac catheterization essentially on a bunch of people in these different age demographics, but they used intravascular ultrasound. So typically it's not until later in the development of these lesions that you actually get narrowing of the vessel. The disease, it sets up shop in the artery wall itself, and even the process of calcification begins in the artery wall itself long before it grows big enough to actually bulge in and start to compromise the lumen. So when you have a typical angiogram, you see the narrowing of the vessel. Well, that's a substantial plaque that has grown out into the that's grown out into the vessel lumen and is narrowing the lumen. Well, you can have already set up substantial amount of disease before you narrow that lumen, and when you inject dye through there, it's going to look like you have a totally patent artery, right? Yeah, good. There's no atherosclerosis there. Well, not so fast. So if you use something called endovascular ultrasound, where they ultrasound the vessel as the catheter goes through it, you can actually take a look at what's going on in the artery wall, and that's how they picked up the data that you see here on this study. So this is it's kind of frightening. It's very eye-opening. And again, it was I had no idea about this a few years ago, and this is why it's changed the way that I look at heart disease as something that maybe, in the past I didn't start thinking about aggressive prevention in people until they were much older. Well, now I think about it a lot earlier, at least screening for risk factors, addressing risk factors at a much younger age than I thought maybe was necessary, say 10 or 15 years ago. So, you can see here, age 13 to 19, well, 17% of those kids already have enough atherosclerosis to be detected on one of these endovascular ultrasound exams. And listen, by the time you hit 50, which is me, 85% of Americans have established atherosclerotic disease. So the development of atherosclerosis in many ways is the norm. And I know that many of you think, well, that's just because we're so much less healthy than we were back in the day, and our Paleolithic ancestors probably didn't have this. And we don't have Paleolithic remains per se, but you know what? We have some pretty old mummies that we found, 3,000 to 4,000, in some cases even 5,000 to 6,000 years old. In one particular case I can think of that were extremely well preserved. Well, guess what? They all had heart disease. They all had established atherosclerosis as well. So it's my opinion, but I think I'm correct on this, that except for there's always some rare genetic mutants out there, right, that don't follow the script. But I think for the vast majority of the humans, vast majority of the human race, all of us are going to die with some degree of atherosclerotic disease. Okay, now does that mean we're going to die from atherosclerosis? Not necessarily. You might die from cancer. You might die from trauma, sepsis. In fact, I'm going to guess here, at the time that this mummy died, I don't know what his cause of death was, but most people died long before they developed symptomatic coronary artery disease, because they probably died of infectious disease, which back then was the leading cause of death. And still, going into the third world, death from infectious diseases, trauma, etc., are way up there as opposed to the Western world. So anyway, I think atherosclerosis is part of the development of atherosclerosis is part of being a human being. Okay, now that doesn't mean that it is inevitable necessarily. Now with modern pharmacological interventions and what we know about the pathophysiology, it is possible to halt the development of atherosclerotic disease and in some cases reverse it. Okay, it depends on how far you are along that chart. Okay, and generally speaking, those stage 5 and 6 lesions, well, you're not going to really reverse those, but you can stabilize them and you can prevent them from growing. We'll talk a little bit about that as time goes on with this talk. But those stage 1 to 3 and maybe 4 lesions, those potentially are reversible, and there's some data that aggressive LDL and ApoB specifically reduction and lifestyle modifications, all of the things we're going to talk about, have the potential to potentially reverse some of those. But once you get established like calcified disease, it's probably not going anywhere. But that doesn't mean you give up. You can keep it from getting worse, and so we're going to talk about that. All right. Okay, let me share with you guys a little bit about my personal and family history as it comes to heart disease. So my dad developed early atherosclerotic disease, early symptomatic atherosclerotic disease in his, I think he was in his mid-50s. He started having pain in his hips and his legs when he would walk a certain distance. So he had classic, what was called claudication. And this happened when I was a young, in my teenage years. My dad was like 40 when I was born, so I had a little bit of an older father. So he, anyway, long story short, he ended up having angioplasty because he had a pretty significant blockage in one or both of his iliac arteries. I can't remember if it was one or just both. So he was already developing symptomatic atherosclerotic disease in his 50s. Now, his father had a myocardial infarction at age 49 and thankfully survived it, lived to be, I believe, 84 and died of pneumonia. But his brothers, he had at least 4 brothers that didn't make it to age 50, that just dropped dead suddenly, presumably from a myocardial infarction. I mean, this is back, in the 50s, and I don't think anybody really knew, but there was definitely a family history there. There was something going on in the background. Something brought on the ship from Norway was causing the men in my family to either drop dead early or have development of atherosclerotic disease a bit earlier than they probably should have. And my dad, like a lot of guys in his generation, Korean War vet, post World War II, everybody smoked cigarettes. So certainly that accelerated things for him, and thankfully my mom got after him, and he quit smoking cigarettes in his mid 40s when I was very, very young. So credit to him for that, because obviously that's not an easy thing to do. But as time went on, my dad developed I can't remember how many actual heart attacks he's had. He's never had like a full-blown STEMI, but he's had multiple what we call NSTEMIs. He was found to have a severely calcified aorta. He's had at least a 3 or 4 vessel CABG. I've lost track of the number of cardiac stents that he's had. So he's what in medicine we call a vasculopath. The other thing, he had bilateral renal artery stenosis, okay, which is restriction of blood flow to both of his kidneys from atherosclerotic disease. Just like you get plaque in your arteries, and he had it in his legs, you can get it to the kidneys as well. And that was manifested by these wildly high blood pressures that led to an incident called Press syndrome. And anyway, long story short, he is a vasculopath. So back when these problems first started rearing their head, I have to give credit to his cardiologist at the time, because this was many, many years ago. He looked at my dad's cardiac risk factors, which, other than family history and his history of smoking, were pretty, and male sex were really non-existent. If I recall, I mean, he had LDL levels that were, for the time, considered very reasonable, like in the 120s to 130s. So this smart cardiologist, I wish I knew who he was, because I'd shake his hand. He's probably long retired now, but he tested my dad for lipoprotein A, or LP(a), and sure enough, it was through the roof. Okay, so that was sometime in my late, I want to say in my late 20s, I think. And then, even then we knew that there was there's a familial component to that. It's autosomal dominant. So I went out and got my lipid panels done and got tested for LP little a, and sure enough, I have very high, pretty what I consider to be high lipoprotein A levels. So my levels are my entire life have typically been about 2 times the upper limit of normal. So if you do it in nanograms per milliliter, the upper limits of most labs is about 30. Mine, typically ran in the mid 60s to low 70s, and they've been that way my entire life. And that's the thing I'll mention to you is, I think everybody should be screened for lipoprotein A, but if you get checked for it and your levels are normal, you don't ever need to have it checked again, because you don't have the gene for this condition. And in terms of when you can be tested for this, let's say for example I'll use my example. I have high lipoprotein A. My son Ronan is 9 months old this week, so it's too early to test him probably, but by age 5, he's going to have the levels that he will have as an adult. So I hope he doesn't get that gene from me. I hope he gets his mom's version of that gene. But time will tell. So the point is, like, if you have children in your family, and if you have a high LP little a, and you've got a 10-year-old, it's not too soon to check them for lipoprotein A, because whatever their number is now is what it's going to be when they're 40, 50, 60, 70 years old, assuming we don't have medications to intervene on it. So, but there's a very strong genetic component, at least a 50% chance that you'll pass that on to your descendants. Okay, so I found out that I had this, this high LP little a level. I don't remember exactly. It was late 20s, maybe like early 30s. So I had graduated medical school already, and I was either in my last year of family medicine residency or maybe 1 year out from residency. But back then we didn't know that much about it. We knew that it definitely was associated with higher risk, but we didn't really have a great game plan for how to address that. And it turns out that it's not much better today than it was back then, but things are getting better. In terms of my background, I grew up as a normal, healthy, active kid. My mom grew up in a farm in Ireland, so she was very much about eating healthy food. We did not eat out. She cooked all of our meals. I didn't even have my first piece of candy until I was about 4 or 5 years old. So sweets and treats and all the crap that you see kids eating today, soda pop, I'm just not part of my life growing up as a kid. And I grew up overseas. I didn't move back to the States full time until I was about 13 years old. So I wasn't raised in this American junk food culture, thank God, that kids are being born into these days. So, and then I had my lipid levels checked at various times in my 20s, like when I was in medical school and residencies, and they were always really good. I've had consistently, for the most part, I've had LDL levels consistently under 100, which back then were basically well, that's the target that you should have if you have coronary artery disease. So they at baseline they're quite good. My blood pressure has always been good. Always have been in the 120s over 80s or less for the most part, with the exception of there was a few times when I bulked up really big in college, and a couple times in early med school when I was competing in powerlifting. So in the off season, I get up to 260 pounds, and I didn't feel good then. I had blood pressures that were a bit elevated, 140s, 150s systolic, but that was not for long periods of time, maybe 6 months at the most. And then I would cut weight for a competition, and my weight has settled down since then. I have no desire to get that big ever again. It was probably not good for me. So there were periods of time, and I didn't get my lipids checked during those times either. I was in a major calorie surplus. I was basically stuffing my face full of whatever I could get just to put weight on, for powerlifting competition. So, maybe my lipid levels at times were above what I just told you. But for the most part, throughout my life, they've always been pretty good. I didn't consider myself to be a candidate for a statin back then. I was just something that I was I'm just going to keep an eye on this. I'm going to continue to eat healthy. My diet naturally over the years has pretty much, before even paleo and Mediterranean became a thing, was basically that, just because those are the kind of foods that I like to eat. I've never been a sugary, sweet carb guy. If anything, I'm a bit of a crunchy, salty guy, so I do like fattier foods. But for the most part, oily fish and salmon and avocados and things like that. I don't even like fruit that much, but I really like vegetables. So my point is that I grew up pretty healthy, and I've had a pretty healthy lifestyle, and all of my other cardiac risk factors were essentially have been non-existent, except for now this Lp(a) thing. So let's talk about Lp(a) real quick. So this is a Lp(a) next to an Lp(a) molecule next to an LDL molecule. You can see that they look very similar, and there's a reason for that. Well, an Lp(a) lipoprotein, it's an LDL, it's a mutant form of LDL. I guess you can think about this. Now, everybody makes Lp(a), to a tiny extent, but there's a few of us mutants out there that make a lot of it, and that's where it starts to cause problems. So basically, it is an LDL lipoprotein, and it's got this added apolipoprotein A component, and it's attached by this little disulfide bridge. It's a very dense particle, so it's arguably easier for it to penetrate into the artery wall and set up shop in there. The interesting thing about Lp(a), I read an interesting paper about it years ago, that the reason it's relatively common, it's about 20% of the population has an elevated Lp(a) level, but it may have conferred a survival advantage evolutionarily, in pre-modern times, because of its ability to embed into the artery wall. It does promote thrombosis, so theoretically, you were less likely to bleed out from, like in women's cases, like from childbirth. Which is postpartum hemorrhage has traditionally been a common cause of maternal death, but just penetrating trauma of any kind, whether it's a Spartan slashing you with his sword or being bit by a saber-toothed tiger, whatever the case may be, there may have been a survival advantage. I think Linus Pauling, the famous vitamin C guru researcher, argued that it was an adaptation to a low vitamin C environment, because humans, I think it's humans and guinea pigs, there may be one other animal, but we're like one of the few animals on Earth that can't make our own vitamin C. And so there's this theoretical protection perhaps from like the ravages of scurvy if you have high Lp(a). So anyway, I don't know how much of that is true or not. But it's just kind of interesting to think about. Anytime you see like something that's harmful, but that's widespread in the population, a lot of times there's a reason that it was there. Like it may not serve a purpose now, but at one point in the past, it may have given people that had it a survival advantage. So, all right, so let's just talk a little bit more about how bad Lp(a) is. I'll just read off the first, the relevant ones here. Myocardial infarctions, the one we're all worried about, 3 to 4 fold times increase of MI. Carotid stenosis, which is a risk for stroke, 1.7 fold. Ischemic stroke, 1.6. Heart failure, 1.5 to 2 fold. And then all-cause mortality, 1.2 times above the average. But the big ones here, coronary artery stenosis, 5-fold, and myocardial infarction, of course, which it makes sense. Also 3 to 4 times. So this is a big deal. Like this is a major contributor to the development of heart disease in individuals that have it. The problem with Lp(a) is there's not great ways to treat it right now. We thought for a while that maybe niacin could be useful, but and niacin does lower, and I'm talking about prescription grade like Niaspan, the extended release niacin, and I took that for about 10 years, maybe a little bit less, until a bunch of studies came out showing that while it made the numbers look better, it did not reduce events. And there's some potential downsides to niacin in terms of hepatotoxicity and worsening glucose control in people who are diabetic. Some of the flushing can be pretty wicked until you get used to it. There's a few tricks to mitigate that, but other than that, there just is not great therapy for Lp(a) lowering. There's some hormonal therapies. Testosterone therapy does reduce Lp(a), probably mostly through its conversion to estradiol, because we know that women who have high Lp(a) levels tend to develop heart disease a little bit later in life than men do. So there's probably a protective effect from estradiol. So, but bottom line, in terms of making like a meaningful dent in your Lp(a) levels, doesn't matter what you eat for the most part. There really is no medication There's very little in terms of lifestyle that we know that makes any dent in this. This is like a purely, you got the short end of the stick when it comes to genetics, and that's just the way it is. Now, there's the new PCSK9 inhibitors, Repatha's one of the brand names. Those are highly effective at just, they crush LDL levels down extremely low, like sometimes under 30. Well, they will reduce Lp(a), but again, it's sort of marginal, I would say. I mean, you're looking at maybe like a 20%-ish drop in Lp(a), but that could be important. But really, other than that, there's just not a great way to lower Lp(a). So if you have a high Lp(a), we'll discuss this a little bit further on, but getting really aggressive with all of the other risk factors that you may or may not have for cardiovascular disease becomes that much more important, because your baseline risk is way up here. So if you can't modify the Lp(a), you have to do everything else perfectly, as best you can at least, to get that risk down by addressing those other risk factors, and probably not probably. I think you need to address them far more aggressively than the average person who does not have a high Lp(a) level. Now the good news is there's some of these like antisense oligonucleotide medications that are going through like phase 3 trials right now, and they've been shown to like radically lower Lp(a). At least in some of the preliminary studies. They're not ready for prime time. It's going to be a number of years before these are going to be like commercially available. And like all of these things that come out on the market that are fancy and new, you expect that they're going to be ungodly expensive. Okay, so but there is some stuff on the horizon that that may offer a ray of hope to those of us with our high Lp(a). Just getting back to lowering Lp(a) with drugs. So this is a chart here. It just shows the common medications and what they do. Common medications that we use to lower cholesterol, specifically LDL cholesterol, and what they do to lipoprotein A. So LDL apheresis. So this is like, I've never even seen this. This is something that I read about in literature. This is where like literally you go to an infusion center or a hospital, and they pull out your blood, they remove the LDL and Lp(a) particles, and they put it back into you. It's invasive. It's sort of like having to go to dialysis periodically. So clearly that way, if you can suck the Lp(a) out of your blood, good luck getting your insurance to pay for that. But you obviously can get some pretty good reductions with that, up to 60%. But statins, very good at lowering LDL. We know that they actually increase Lp(a) a little bit by like 11%. Now, you're going to say, well, why the hell would you take a statin if you have high Lp(a)? Well, you got to remember, like, the total number of ApoB particles is probably the best way, in my opinion, to measure your overall atherosclerotic risk. And as bad as lipoprotein A is, it does contain ApoB. It's a pretty small contributor to that overall ApoB number. So despite raising your Lp(a) just a little bit, the massive reductions that you can get with statins and other LDL lowering medications is enough to offset that slight increase, at least statistically. So, but just be aware, you will see that, and you may wonder like why your doctor is recommending a statin for you when you have high Lp(a). Well, that's the reason, is that the net benefit, despite the slight increase in Lp(a), is still there. And as I mentioned, the PCSK9 inhibitors, they will lower Lp(a). Here they say reductions up to 20 to 30%. I already mentioned niacin. Niacin does drop at 20 to 30%, and I noticed that too when I rechecked it when I was on niacin, and yeah, it went down 20 to 30%. So I was like, woo, cool. And it made some of my other numbers look a little bit better too. But now in hindsight, I know I probably wasn't doing much to prevent my to prevent the progression of disease and to reduce my risk of an event. So that's why I don't take niacin anymore. Okay, getting back to me. So when I turned 40, obviously at that point, like my dad was well into his cardiovascular journey. He'd already had a few other issues. So, he had his first issues cropping up in his early 50s. I was like, okay, why don't I screen myself with one of these tests like 10 years before, roughly 10 years before he started having problems. That seems to make sense. I mean, we do that with like colon cancer screening. So that's what I figured, well, that's what I'll do with my heart disease screening. So I had a coronary artery calcium scan right when I turned 40. It was 0. All right. So I was like, sweet, I'm happy. I don't have any calcium. And that's, that is a good sign. And it was. So at that point, again, all of my other risk factors were negligible, including, I had an undetectable CRP. My homocysteine was normal. I've always had, like I said, really good blood pressures, under 120 over 80. Gosh, what else? Oh, I checked like an oxidized LDL level, like all that stuff that's probably not that important. All that looked great. So I was like, you know what? I'm just going to keep taking niacin. And then I stumbled upon panathine, so which I'll talk briefly about. And so I started taking some panathine. Panathine's a derivative of vitamin B5. It kind of like niacin. It makes all the numbers look better. Probably doesn't. I don't think it has any effect on lipoprotein A, but it is essentially side effect free. We have no idea whether it actually lowers event rates, but it does make the numbers look pretty, and it's very safe. So I was like, you know what? Why not? I'm going to take it. It's dirt cheap. So I started taking that as well. And my numbers, again, they've always been really good. So these are 2 lipid panels that I've had over the years. I think that this was like 2000. This first one here, this is 2016. So yeah, my LDL was 94, HDL was 43. These were not fasting, by the way, so my triglycerides were for me, a little bit elevated. When I fast, my triglycerides are like 40. I don't really do fasting lipids anymore, except in specific cases. I don't find them that useful. In this one here, I had an NMR profile done just to get a little bit more information. My LDL particle number, pretty good, under 1,000 is 901. My LDL at this point, LDL-C was 74, so like pretty damn good. My particle size, you can see a tiny bit on the small side, likely irrelevant. So, this is looking pretty good. So I was like, let's just continue on. And, my plan has always been to check another coronary calcium scan 10 years later and just kind of reevaluate things. And that leads us up to where we are now. So I went to the VA, which is where I get my health care. Thanks, VA. And got my CT scan, and here it is. So I now have detectable plaque. So I did have a score of 0, and now I have a total score of 16. These in what they call Agatston units, named after Dr. Agatston, famous cardiologist. I think he was also, if I'm not incorrect, the inventor of the South Beach diet. Is it South Beach? Yeah, I think it's South Beach diet. Anyway, a little trivia for you. So for a guy my age, this is not good. Now, granted, overall it's low, but it's really, like, I was shooting for 0, but I don't. So I have coronary artery disease. I have calcified coronary artery disease, I should say. So you can see here they break it down by artery. Left main is 0, thank goodness. That would be bad. The LAD is quite low at 2, which is also good because the LAD, that's not a good place to have disease. My circumflex is 4, and then it cut it off. The remainder is in the right coronary. Okay, so most of my calcium is in the right coronary artery, and so presumably most of my atherosclerotic disease is there. Okay, and just to kind of put these in a bit of context, this is how they score these things. So at 0, it says no identifiable plaque. The risk of an adverse event is very low. I'll talk about this maybe a little bit more later, but that's not a correct statement. No identifiable calcified plaque. There absolutely can be non-calcified plaque there, and certainly there is. So just because you have a calcium score of 0 does not mean you have clean clean arteries. Okay, you could actually still have substantial soft plaque there, but it is still good. Like it is obviously 0 is where you want to be. 1 to 10, minimal plaque burden, risk of an adverse coronary event is low. And then it jumps up from there. So 11 to 100, they call this a mild plaque burden. They call it moderate risk. Yeah, I guess it is. And then obviously it goes up from there. Greater than 100 is you got to really start being concerned at that point. There's some thoughts that when you get over 100 and certainly like over about 300, that maybe you should start taking daily aspirin, like a baby aspirin as a preventative, because the rates start to, the rates of myocardial infarction over the following 10 years tend to be, they start getting close to where you look at the rates of people who've already had an MI, and they, those patients typically qualify for aspirin. So they start getting closer. And so the thought is, based on this calcium score, that you may want to start taking an aspirin. So that's, I don't know that that's been completely validated and worked out yet, but it's, you'll see some literature on that or your doctor might mention it to you if this comes up. So once I got that score, I was aware of this MESA study, which is a kind of a big study in the cardiology world that I had read about when it first came out. But you can go to this MESA website and you can do a coronary artery calcium calcification score here. So you can put in your values. I rounded up to 50. Okay, I was a month off. I'm technically 49 still, but whatever. We'll call it 50. You put in your gender, not what you identify as, but what you are biologically. Your race, and then your Agatson's calcium score, which is 16. That puts me in the 72nd percentile. If you do an arterial age calculator, which you can also find on this site, that unfortunately gives me an arterial age that's about 10 years higher than what my actual chronological age. Okay, so that's unfortunate. Unfortunate for me. Okay, so again, the limitations of coronary artery calcium. It is a good study to get, but you just got to understand, just like anytime you order any test in medicine, you got to understand the limitations. Again, it doesn't visualize soft plaque. So, I may have very little soft plaque. I could have a 50% soft squishy lesion in my LAD that would not even show up on a coronary artery calcium scan. Now, the chances of me having that are relatively low because I have no other cardiac risk factors. But as I'm going to show you, there's case studies of people coming in with, with myocardial infarctions found to have really significant stenosis, and they have 0 calcium scores. So just be aware of that. This test is not perfect. So you can still have soft plaque, and in many ways, an inflamed soft plaque may be more likely to rupture than an old, calcified plaque that's just sitting there like a boulder. So if you really want to, the best study to look at that currently is probably a CT coronary angiogram, so where they squirt dye through your vessels, and then you can visualize soft plaque that way. But those are expensive. Good luck getting your insurance to pay for that, especially if you're asymptomatic. You're not going to get it as a screening test, and it may not even be available in your area. The good news is the regular old CT coronary calcium score. In my local area here, you can get these without a doctor's prescription even, and they're about $100. So a CTA out of pocket is going to vary depending on where you live, but it can be well over $1,000 if you can't get insurance to pay for it. So which is probably going to be the norm. So let's talk about what it means to have a 0 calcium score. So obviously that's great. Okay, it's I'll show you some numbers here in a second, but the problem with having a coronary artery calcium score of 0 for many patients, that it lulls them into a bit of a false sense of security. So, I've seen this before. Obese, pre-diabetic or diabetic person comes in. Their diet, of course, is garbage, because that's why they're obese and diabetic. They're not exercising, but they have a lipid panel maybe that's not so great. They get a bit of a scare, and they come in and they get a calcium score of 0. So what happens, of course, they're very relieved, as they should be. However, it lulls them into kind of a false sense of security, and it in some ways validates the poor lifestyle decisions that they've been making, and it disincentivizes them to make those changes that they need to make. And they're not understanding that, just because they don't have calcified plaque doesn't mean that they don't have significant soft plaque, and it doesn't mean that every single day they're not just continually laying down more plaque. It's just that it hasn't calcified yet to a level that's detected by this scan. So it doesn't mean that and if they were to do this test again in 10 years, that it wouldn't show positive, or that if the very next day we took them down and did a CT coronary angiogram, that they wouldn't already have significant amounts of soft plaque. So it definitely is a double-edged sword. It can be highly motivating if you have if you have detectable calcium. It can be kind of a wake-up call. But I've also seen it be, give you guys a false sense of security, and help people sort of like just continue in their poor lifestyle choices and not make the changes that they need to make down the road. So just something to be aware of. This is a kind of a case study that talks about exactly what I was just talking about here. So this is an example of a 62-year-old lady, morbidly obese, high blood pressure, cholesterol, that came in with chest pain that sounded concerning, and was admitted to the hospital. I think she ended up with a positive troponin, if I remember the story. So on the left here where it says B, this is the initial CT obviously with no contrast. Her calcium score is 0. So they're like, okay, well this bodes well, but this lady's got a troponin, she's got all these other risk factors. Long story short, she went to cath, and you can see here in D, the red dot, there's clearly like a big lesion there, and that's the LAD. Okay, and then afterwards here in E, after it's been stented, you can see all the blood going through there. So this is a great example. I mean, this lady was 62, she had all the risk factors, she came in with a myocardial infarction, and had a CT calcium score, a bit surprising. It was 0. Okay, and she ended up having, this is a 90% proximal LAD lesion. So it's not impossible, and so that's why I say, obviously I'm happy for you if it's a 0, but that doesn't get you off the hook. You can be 30 years old, have a bunch of risk factors and terrible lipids, and die of a myocardial infarction from a ruptured atherosclerotic plaque, and still have a 0 calcium score, because it just hasn't been enough time for the calcium to deposit and stabilize that plaque. Which, by the way, that's the reason the calcium is there. And this is, I don't want to digress too much, but that's an important distinction. People freak out about the calcium number. The calcium is not what's harming you. The calcium is just a marker that we use to identify the plaque. The plaque is what's going to kill you. In many ways, the calcium you could argue, is beneficial because it helps with stabilizing the plaque. So that's why it's hard to assess, like, over time by getting these repeated calcium scores, especially if you're on a statin, which statins will increase your coronary calcium score for a variety of different reasons. But just because that score is going up doesn't necessarily mean that you're developing new plaque. Okay, that's why this is not a perfect test. I think a CTA is a much better test, but it's just something to keep in mind. It's not the calcium that's going to kill you, it's the plaque. Okay, so don't get too fixated on that number if it's going up a little bit over time if you're on a statin, because now if it's going up, you're not on statin therapy and it's going up and up and up, that's probably more concerning. Okay, but just to give you guys an idea, I mentioned that MESA trial before. So if you have a coronary calcium score of 0, and you're between the ages of 55 and 64, by the way, that's what they looked at. So in that group, over the following 10 years, 3.1% of those people had cardiac events of some kind, whether stroke or a heart attack. So that's pretty low. But if you did have detectable calcium and it was above 300, so 16.7 of those people had a myocardial infarction, stroke, etc. So there's definitely a correlation there. But again, 3.1% of them still had an event despite having a calcium score of 0 within that 10 years. Okay, so this kind of circles back. The 10-year thing circles back to one of the issues that I have with the way that we assess risk, and everything is looked at in 10-year increments. What is your chance of having an event over the next 10 years? And it's not like that is useful, of course, but I plan on living a lot longer than 10 years from here. My goal is to make it well into my 90s, and not just make it into my 90s and be in a diaper at a nursing home, but living independently, doing what I want, and still being able to travel, drive a car, like go up and down the stairs without without assistance, that kind of stuff. And so again, we go back to, we know that atherosclerotic disease starts in childhood, and it takes a foothold in the artery at a very, very young age. And so, the plaque that kills you, let's say at age 70, it didn't pop up overnight. I mean, that plaque started growing maybe when you were a teenager. So I'm not advocating that we put teenagers on statins, but I think taking a much longer range approach is much more important. And getting all of these risk factors that will lead to atherosclerotic disease as low as possible. There are people out there, there's guys like Peter Attia and Tom Dayspring, that argue that really, like, nobody should die of cardiovascular disease. And obviously that's not realistic, but with the therapy, what we know now, with the lipid lowering therapies that we have and all the other agents that are available and in the pipeline, it should be possible to stop the progression of atherosclerosis at a certain point in your life when you initiate all of those therapies. So you may have a certain amount of plaque, but it may not be possible to reverse it, but it certainly seems to be possible to stop it in its tracks. And then, you can live another 40, 50 years not having a cardiovascular event. I don't know, maybe you'll die of cancer, maybe you'll get hit by a bus, I don't know. But, that's my issue with these 10 years. They only look out for 10 years. So, a person who has multiple cardiac risk factors, who's 25 and has, high ApoB, but has for some reason somebody gets a calcium score on them at 0, well, they're basically going to say, we know for a fact that person has plaque. All of their risk factors are screaming at us that every day they're laying down a little bit more lipid in their arteries, but we're not going to stop that process, or we're not going to do anything to slow it down until this 10-year calculation that somebody made up shows that their risk goes above a certain threshold. I understand doing that from a population standpoint and like as a cost-saving measure when you're looking at treating hundreds of thousands of people, but as an individual, that doesn't work for me. That doesn't work for me at all, because I want to look a little bit further down the road than 10 years. Okay, what am I going to do? What am I changing, and what am I going to do to address this admittedly like pretty low overall calcium score that I just discovered that I had. So what this tells me is that despite a really good lifestyle, despite essentially negligible cardiac risk factors with the exception of lipoprotein A, and despite having an LDL level consistently, for the most part, under 100, over the last 10 years, I have had the progression of atherosclerotic disease. Okay, so this is just, it's a bit, even now, like this is eye-opening to me that, perhaps many of the guidelines that we have told patients in the past are adequate are really not adequate in terms of stopping disease. They may slow it down a little bit. Certainly we know like an LDL of 120, you're less likely to have as rapid a progression as you would if it was 180. Now granted, there's a lot of other factors there that are involved in that, but it seems that possibly LDL levels of 100 will still allow some, while they're okay, are still going to allow the progression of heart disease, especially in someone who has high lipoprotein A. So this tells me that in my case, I need to be much more aggressive in lowering my ApoB level, because again, remember, ApoB is the causal agent in cardiovascular disease. I understand about inflammation, I understand all these things with particle size and whatnot, but the number one thing, the causal agent of the development of atherosclerotic disease, guys, it is ApoB. So that's what I'm going to focus on here. I can't focus on blood pressure. My metabolic health is excellent, but I can't change my genes. So I have high Lp(a), and other than Repatha, currently there really isn't anything on the market that is going to lower my Lp(a). So what I need to do is lower my ApoB/LDL level as low as possible. So let's look at what some of the guidelines out there say about that. So this is from the European Association of, European Society of Cardiology. They're a little bit more aggressive than their American counterparts, but you know, their messages are essentially the same. The numbers are just slightly different. So what they talk about here, it says in primary prevention for individuals with FH, so familial hyperlipidemia at very high risk. So they're not talking about LP-little-a people, but LP-little-a people are in the high risk category, okay? It says an LDL-C reduction of at least 50% from baseline and an LDL-C goal of less than 55 milligrams per deciliter, okay? That's what they're shooting for. So for high risk patients, which having high LP-little-a makes me high risk, and the fact that my disease has progressed over the last 10 years, despite otherwise what I think most people would agree are pretty good numbers, that puts me in the high risk category, okay? So I'm gonna get my LDL under 55. And they also mentioned getting the ApoB level under 65, okay? So how am I gonna do that? So I'm not on niacin anymore. I'm staying on panathine. I don't know if it's helping me or not, but I'm gonna stay on it. I feel like it's at the very least, it's harmless, but I am now on 40 milligrams of atorvastatin, 10 milligrams of ezetimibe. I'm gonna redo my lipid panel, see where I'm at. And then, you know, the VA will not pay for Repatha for me because I haven't had a heart attack yet. So I have to wait to get a heart attack first, and then they'll pay for it, which is actually not, I'm not even too upset about that. I mean, that's how all insurance companies are in the United States. They would rather you have a heart attack, and they would rather pay the tens of thousands of dollars to treat your heart attack and then put you on Repatha than they would to put you on Repatha to hopefully prevent you from having that heart attack in the first place. It's so back-asswards. But hey, welcome to the collapsing American healthcare system, okay? So, you know, unfortunately right now, Repatha, it's about $600 a month without insurance here locally, and I think that's pretty average from what I've seen nationwide. That's a lot of dough. So I'm thinking about that. I'm going to see how things go here in the next like 3 to 6 months with this regimen of panathine, Zetia, and atorvastatin. I want to see what my ApoB numbers do, see how I feel, etc. But really, like, I want to get my LP-little-a levels down because, you know, that's mainly the issue here. I don't really have a huge LDL problem at baseline because, like I said, they're naturally pretty good. I have an LP-little-a problem, so I would much rather address that. But we just have there's just like a total dearth of research on outcomes with LP-little-a lowering, and again, these new drugs that are in the pipeline, it's going to be a number of years before, you know, Joe Schmo like me is going to be able to, even as a physician, going to be able to get a hold of these things. And again, I guarantee that if I want to be on one of these things, I'm going to have to pay for it out of pocket because not just the VA, but no insurance company is going to fork out the dough for this because I haven't stroked out yet and I haven't had an MI. This is just it's a good example. Even me, I'm a doctor. I'm pretty well versed in this stuff. You have to take your health into your own hands, guys. This is the way. If you think it's bad now, just wait 10 years. You know, the way that healthcare is going, there's going to be rationing. There's going to be a whole bunch of these really new fancy drugs, you know, many of which may be miracle drugs, but they're going to be cost prohibitive without prior authorization from some big insurance company, government agency, whatever. And if you don't have insurance, or you don't meet whatever their qualifications are, too bad. Okay, you're gonna have to pay for it out of pocket, which the vast majority of people cannot afford. You know, hundreds, maybe even $1,000+ a month to take a medicine that could prevent them from having a heart attack in 5 years or 10 years. That's all I have to say with you guys. I just wanted to share that with you. You know, cardiovascular disease is a big deal. Like, I don't care if you're 19 years old, you really, really, really need to, you should know what your lipid levels are like. You should make sure that your blood pressure is as good as it possibly can be, ideally under 120/80, based on various trials. You know, if you've got a strong family history, you really need to double down. If you are overweight, for God's sake, there's just no excuse. Like you have got to get that handled. If you are pre-diabetic, if you have fatty liver, which a gigantic proportion of the under 30 population in this country is obese by body fat percentage, has fatty liver disease, which is a major risk factor for cardiovascular disease. If you have any of those things, for God's sake, unless you want to get sucked into this sick care system, you need to get that addressed like now. Because I'm telling you, I know what's coming down the pipeline. My colleagues, we all know what's coming down the pipeline. You guys don't, but you're going to find out because the system is collapsing and it's not going to be pretty. I hope you guys are all well, and I will catch you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.